Good evening. My name is Bob Akivi. I am your moderator tonight. Tonight we have the pleasure of having an expert panel on treatment of nasopharynx cancers. Without further ado, I am going to introduce our panelist and moderator. Welcome from a very hot New York City this evening. This webinar has been made possible by a generous educational grant from Coherus. However, AHNS has full independence in terms of content and editorial review. There's been no input from the company. Our panelists tonight are Dr. Nancy Lee, who does not need any introduction in any head and neck society meetings. She is attending radiation oncologist and vice chair of experimental therapeutics at Memorial Sloan Kettering Cancer Center in New York City. Dr. Chui Meng Lim, associate professor of otolaryngology and vice chair of research at Singapore General Hospital and Duke National University of Singapore Medical School in Singapore, and Dr. Anna Esprifico, associate professor of medical oncology from Division of Medical Oncology at the University of Toronto in Toronto, Ontario. Welcome all. Thank you for accepting our invitation. Very looking forward to hearing your talks. And my friend and my co-moderator tonight is Dr. Michael Moore, who's the professor of otolaryngology and vice chair of otolaryngology in Indiana University. Dr. Moore will present the cases today. All right, Mike, take it away.
Thanks, Dr. Givey. Welcome, everybody. So yeah, just to get us warmed up here, we'll present our first case, which is just a primary presentation. 47-year-old man comes into the office, usual state of health, with a complaint of bilateral neck masses. Ultimately work them up and find to have significant levels 2 through 4 lymphadenopathy that's mobile but a little tethered, and endoscopic exam shows this kind of friable ulcerative lesion in the nasopharynx. Biopsy shows this to be the neck lymph node showed it to be poorly differentiated squamous cell carcinoma. Here's a PET scan. And so you see the primary tumor in the right nasopharynx and significant bilateral cervical nodal disease. And here's the MRI images as well.
So it's classic presentation in the United States, bulky disease, bulky primary. So the question for the panelists is, what's the state of the art in 2024 for NPC treatment? Part one is Dr. Lee. We've been talking about modern radiotherapy techniques in the treatment of nasopharyngeal cancer. Dr. Lee?
Sure. Thank you so much, Babak and Michael, and thank you so much for having me. I thought I would take this opportunity to just give a very quick summary of what is the current standard care and where technology is incorporated for the treatment of NPC, typically a non-surgical disease. These are my disclosures outlined here. Now, in the 1990s, I just want to call everyone's attention. Recall, this disease was a RT alone disease. And then we introduced chemotherapy based on this intergroup 0099 trial. We show that concurrent chemo radiation followed by adjuvant chemo versus RT alone was superior to RT alone. You can see these curves are so significantly in favor of chemo radiation that it was unethical to treat any local regional advanced nasopharyngeal cancer with radiation only, and that has thus established a standard. In the year 2000 onward, this is when we introduced intensity modulated radiation therapy. Now, I was trained in the 2D era. On the left, you can see here's a nasopharyngeal cancer. Here are your parotid glands. And then because you have to go from the right and left in a post-lateral technique, you wind up radiating everything because you got to get to the middle. Everything gets the full dose. Now, there's a certain way of, we do brachytherapy, different things, but in the end, lots of dose to all the normal tissue. On the right is our intensity modulated radiation therapy. Now we're modulating the dose, and you can see now how these curves are curving around where we want to treat while sparing the normal tissue. And namely, IMRT first came about. What we can see in the clinic is the effect of less dry mouth. Now, in nasopharyngeal cancer, especially, just like our case before, you get tumor up to the sphenoid sinus and the ethmoid sinus, and here's the orbit. you can't do a post-lateral because you're going to wipe out the orbit. You're going to really cause optic neuropathy or blindness or temporal lobe necrosis. So here with IMRT, you can see the blue line really hugs around the tumor while sparing all this normal tissue. Now, IMRT, what is the data? We have done this study in energy oncology or RTOG. We have shown that you did not miss tumor. That was one of our fear, that when we go to more conformal, precise radiation, am I going to miss tumor? And the data shows we did not. It's sort of like your open surgery to your endoscopic surgery. Are you going to miss tumor? But the problem with NPC is what? That, yeah, we control local regionally, but you look at the PFS and OS, it's not that much different than the conventional RT. Why is that? Well, simply we changed the pattern of failure from local, regional, predominantly to now distant. So we did not improve the overall survival. Look at 76% IMRT era versus 76% in the old conventional era. So what have we learned? Distant metastases remains a problem, difficult. And then we also realized part of the reason is it's very difficult to give adjuvant chemo. This is why there's a revisiting of induction chemotherapy. And as you know, this was published in New England Journal of Medicine by our colleagues from Sun Yat-sen. We simply shifted the adjuvant chemo that was a standard followed by concurrent to upfront induction chemotherapy. So you give induction first, followed by concurrent. Sort of like the case that was presented, probably most people will give induction first, and they survive, and there is definitely survival advantage in favor of induction, followed by the concurrent chemoradiation. Now, we don't have a good study comparing induction followed by concurrent versus concurrent followed by adjuvant. That, I don't think that study will ever be done. So we have two different ways to treat, if you will. Now, I did want to talk about proton therapy because everyone talks about it. It's just a bigger donut. From a patient point, you lie flat on the table and look at how small IMRT machines are. You lie flat, patient experience the same, but you have a bigger donut radiating. This is the concept of Bragg peak. What is the Bragg peak? Well, you shoot your particle therapy and then you don't have any exit dose. This is all the normal tissue here. Whereas IMRT, you exit through on the top, you see all the mouth sores on the bottom. You don't see anything because we can simply stop the beam. Then you can modulate. Tumor's not this small. You can modulate it. And then when you modulate it, you get increased skin dose. That is why you see proton patient having more skin toxicity. Beauty about NPC is, look at this. I can spare now everything else that IMRT can, plus I can spare the oral cavity, which is a huge gain. And here you can see these different panels. And on the right is all the unnecessary radiation a patient gets as a result of IMRT. If you use proton, you spare all this normal tissue. And then the other thing I just want to point out to the group, I saw this in our patients, but I can't prove it statistically, is the proton had better control rate. See, it's approaching significance and thus better progression-free survival, especially your T4 tumors that's going intracranially. But the Taiwan group, which has more NPC, they show statistically more significant. Also, the curve separating. So that's something I want to drive home, that for NPC, proton has that added advantage. But lastly, I want to end by saying, let's be smarter. Look, technology is technology. What we really want to do is precision medicine. TNN stage is not going to do it. This is the concept of liquid biopsy, EBV DNA. And this concept, Dennis Lowe is what you call the godfather of all liquid biopsy. Right now, everybody's talking about liquid biopsy, selfie DNA, NavDx, whatever. But EBV DNA was the very first. This was done in the 1990s. And then you can see patients that have tumor have higher plasma EBV DNA versus control. And we designed this trial, Energy Oncology. Happy to say that the results will be reported in 2 years. What we did is we want to personalize. After your treatment of chemoradiation, if you're undetectable EBV DNA, you get to be observed versus the current standard of adjuvant chemo. And we have a phase 3 randomized, it's 632 patients. And then there's a phase 2 randomized, a high-risk patient. You have persistent EBV DNA, then we will compare to different chemotherapy regimen. And of course, now I don't have time to get into it, the immunotherapy, but lots of permutation. But the bottom line is we are now trying to personalize therapy to say who really needs that additional chemotherapy because it's toxic. Conclusion, chemotherapy followed by adjuvant or induction followed by concurrent is the standard care. I think proton therapy, if you have access to it, can diminish toxicity, maybe improve survival and local regional control for T4 disease. EBV DNA can guide therapy. We really await the results of Energy Head and Neck 001 to see if we can change therapy. And lastly, there's some other important things, exciting, we don't have time to talk about, especially Babak will know I'm very into de-escalation strategies, something that we want to start very soon. Thank you for your attention.
Amazing talk. Thank you. I think I learned more about radiation and NPC in this 10 minutes than I've ever learned. Since we have about 1 or 2 minutes, a couple of questions for you. Number one, do you differentiate between the dose of radiotherapy between the primary tumor and the neck nodes? And how do you arrange your field that how much radiation? So for someone like me, a patient comes to me and says, I'm going to go get radiation. How could I talk to them intelligently? What is it? How do you design your radiation field?
Very good question. If in terms of gross tumor, whether it's the lymph node or primary, it's all going to get 7,000. That is very standard. And you nailed it, Babak, that the subclinical region, right? Your sinuses, your rest of the neck that doesn't have any gross disease. At Sloan Kettering, we give about 40 gray, but other centers may give 63 gray, 60 gray. So you can imagine the toxicity is very different from centers to center. We don't have a good randomized study comparing the subclinical disease. The best analogy I can think of is a surgeon. How much additional normal tissue are you going to cut? Some places will be very tight. Some places like, I want to take a centimeter more margin. So that's very different depending on the center. And when you counsel your patient, you can say, not everything is going to get 70 gray. You're going to get a big field, less dose radiation, and then you get into the gross tumor, more radiation dose.
Amazing. So thank you so much. Appreciate it. All right. Well, we're going to present our second case. Let's see if I can share real quick, and then we're going to continue. All right. Here's the second case. Mike?
Yes, that was a tremendous overview, Dr. Lee, of primary therapy. And obviously, in that setting, it's pretty rare that surgery comes into the fray. I think this next one, certainly there could be a little debate on the approach that would be used to care. And so we'll present this and then hear from our last two experts on their approach, not just necessarily to this patient in particular, but more towards salvage treatment of nasopharyngeal cancer. So there's a 20-year-old male who came in. He had been previously treated with induction chemotherapy and subsequent chemoradiation therapy about 9 years ago for a T1N3 M0 EBV positive nasopharyngeal cancer. Initially had a complete response, but was lost to follow-up, and then ultimately had, but at the time of his initial surveillance, had been undetectable in his EBV titer. He then represented at the end of last year with a left neck lymph node that was biopsied and found to be positive for recurrent disease, and had a left ear effusion. Physical exam on scope showed this hypervascular fullness in the left lateral nasopharynx, and biopsy that also confirmed additional site of disease, had some mobile left level 2 and 3 lymphadenopathy. So this just shows his primary disease around the eustachian tube itself, with no frank extension into the pharyngeal space. If you go down a little lower, though, we did have some nodal disease. There was not only a retropharyngeal node, but then on more laterally, you can see the level 2 and 3 nodes as well.
Okay, so presentation of a recurrent metastatic disease. Now we're going to go to the second part. Dr. Sprifico are going to talk about new frontiers in management of recurrent metastatic disease, and then Dr. Lim will talk about surgical salvage. Anna?
Good evening, everyone. I'm gonna share my slides. So glad to be here this evening virtually. I want to thank the American Head and Neck Society for inviting me to be part of this virtual education series. And tonight I'm going to provide a brief overview on the management of recurrent metastatic nasopharyngeal cancer. And here's my disclosures. So as a way of background, I want to remind everyone that nasopharyngeal cancer is a rare type of cancer in most parts of the world, except in the area where it's actually endemic. And these include southern China, Southeast Asia, North Africa, and Arctic. There are mainly three subtypes of nasopharyngeal cancer, those described as undifferentiated non-keratinizing, so type 3 and 2, mostly associated virtually all of them associated with the EBV infection, and then the keratinizing, which is more frequent in the endemic area, while the keratinizing is more frequent in the non-endemic. We heard before that just previously by Dr. Lee that fortunately with the novel technology and the new treatment, we are able to cure most of the patients who present with locally advanced disease. However, about 20 to 25% of patients unfortunately develop either local recurrence and, as we heard, several of them would develop metastatic disease. And when that happens, the treatment of choice is generally considered systemic, and it's considered palliative in nature. The backbone, we heard about it in the curative setting, but also in the palliative setting is chemotherapy with the platinum base with an objective response rate that were described around 64%. And a median overall survival of 29 months. However, increase and prolongation of survival is possible, and we have seen it, especially when we select the patient carefully and we treat them appropriately. For endemic NPC, importantly to highlight that it's characterized by high PD-L1 expression and high infiltration of non-malignant lymphocytes. Nowadays, and relatively recently, anti-PD-1 immunotherapy has been incorporated in the first-line setting. And so when we deep dive in the first-line setting, the data supporting the use of anti-PD-1 in combination with chemotherapy are coming truly from 3 pivotal studies looking at 3 different anti-PD-1, all of them anti-PD-1 treatment. CAPTAIN-1 looking at camrelizumab in combination with cisplatin or gemcitabine versus placebo, so versus chemotherapy alone. Jupiter-2 looking at toripalimab, and Rational 309 looking at tislelizumab. All of these were phase 3 trials, and if you can look at the table, most of the 3 studies actually had very similar number of patients enrolled, and the subtype evaluated, so the patient population was mostly patients with non-keratinizing type 2 or 3. The median overall survival, which was the primary endpoint, was around 10 months. At the time this trial was reported, there was no reaching of the overall survival, and the objective response rate, as you can see here, are quite high. And I put this slide here just to show that virtually the 3 trials had the very similar, actually exact same trial design. Randomization with the primary endpoint, all of them being progression-free survival. And as you can see in the curve look very, very similar. I said the progression-free survival is pretty much overlapping in all of the 3 trials with an hazard ratio of 0.5. In October of last year, FDA has approved toripalimab, the anti-PD-1 toripalimab, in combination with chemotherapy in the first-line recurrent metastatic nasopharyngeal setting, and has also approved toripalimab to be given as a single agent after progression on palliative chemotherapy. And this is the updated results that were presented at the last ASCO meeting with an overall survival updated 5 years of 52% in the Jupiter study for chemoimmunotherapy as compared to chemotherapy. That said, those study, I want to remind everybody, including the what we define as the endemic NPC. They were mostly run in Asia. The North America, so non-endemic nasopharyngeal cancer population is a rare population that unfortunately has been historically kept outside of clinical trial, and there are no large study. I have summarized here I would say a snapshot of some of the small study that have looked at outcome of patients with nasopharyngeal cancer in North America, with a large population of white rather than Asian or African American, with either an EBV positive disease or HPV positive disease. And as you can see on the far right, on the last column, the outcome, so the 5 years overall survival ranges from very low up to 18% low up to 70%, with EBV negative tumors as a message that show a trend towards a worse overall survival, with all cases occurring in white patients. Because of that, RTOG Foundation has launched a post-registrational study looking at toripalimab in combination with cisplatin and gemcitabine in the first-line setting to really look at the outcome, with the primary endpoint being objective response rate of patients with nasopharyngeal cancer representing the North American patient population. Beyond this study, I want to point out also another efforts from the cooperative group NRG, AHN011 or REMAIN study, looking at maintenance, the maintenance question in the treatment after first-line therapy. This is a study focus on EBV-associated recurrent nasopharyngeal cancer, looking at the use of nivolumab maintenance versus nivolumab and relatlimab maintenance following the chemoimmunotherapy first line. So we have achieved a lot, and we're using immunotherapy and we're prolonging the life of our patients. However, some patients would ultimately progress even after receiving a benefit from the first line. So what do we do in the beyond first line? We do know from previous study that anti-PD-1 is not better than chemotherapy in the post first line setting, and we learned that from two large studies. So there are lots of clinical trial ongoing. I just wanna kind of briefly update the group here with respect to some of the trial looking at targeted angiogenesis. Those are all small phase 2 studies, single arm studies, small numbers, but also point out that there's tons of other research ongoing and clinical trial looking, for example, at EBV targeting immuno with cell-based therapies, EBV latent proteins targeted therapeutic vaccine, or induction of EBV lytic cycles, as well as non-EBV targeted immune therapeutics in the nasopharyngeal cancer space with immune checkpoints. We've heard a few of them. I want to point out the novel antibody drug conjugate and the bispecific, and suggest to look forward towards the presentations at ESMO meeting, because there are some interesting upcoming data that we all expect, as well as effector cell and TCR-based therapies. So as a take-home message, I want to remind everyone that endemic and non-endemic NPC represent two different entities, and we yet don't know, although we are incorporating the use of anti-PD-1 with chemotherapy in the first-line setting, whether or not non-endemic NPC will benefit the same, at least the same, or better or less of this therapy. There are other ongoing clinical trials evaluating alternative maintenance treatment post-chemoimmunotherapy, and that's another area of important investigation. And beyond first line, lots of clinical trial ongoing, but probably even more needed in order to identify more treatment options for our patients. And with this, I want to thank everyone for the attention.
Perfect. Well, thank you. This was amazing, very comprehensive overview. Actually, now I think I can understand something about the recurrent metastatic. So just a couple of clarifying questions for you. So today, if let's say that first patient shows up in your office, you recommend induction chemo, which is gemcitabine plus cisplatin. Is that what we do nowadays? No immunotherapy.
So if the patient has locally advanced disease, as Dr. Lee has mentioned, large tumors, bulky nodes, we do induction chemotherapy with cisplatin and gemcitabine. We do have the data with that. And then we following short staging, generally 3 cycles, then we go on to receive radiation. I know that in the US it's done proton when available, otherwise chemo radiation. In the recurrent metastatic setting, what I would recommend is based on these 3 large study, it would be to use the chemoimmunotherapy. That said, as I mentioned, we're looking at a patient population that is not representative of those patients who were treated in the large phase 3 trials.
So if immunotherapy seems to be working in recurrent metastatic setting, and if all this stuff that we do, this is still a disease that 70-80%, so 20-30% of people will die. Is there any trials for incorporating immunotherapy as first-line treatment in non-recurrent disease?
Into the induction, you mean?
In just the treatment of de novo cancer, not recurrent metastatic.
Yeah, so this is not done routinely. Certainly not in Canada, and I don't believe it is done either in the United States. But there are lots of clinical trial evaluating the role of adding immunotherapy into the kind of induction component as well as following that. So similarly to what is being done for many other diseases, including head and neck squamous cell carcinoma, lots of clinical trial looking at incorporating immunotherapy.
Okay.
Yeah, and back up to that end, that in Sun Yat-sen did the large randomized study that was recently, I think, published in Lancet. But it was a study done in China. It's not incorporated in the United States or Canada. There's a lot of questions, as you know, should we give immunotherapy concurrent with radiation? There are 8 randomized studies in head and neck squamous, it's negative. In lung, it's negative, right? And then in cervical cancer, negative, that there's concern to give it concurrently. But Sun Yat-sen did conduct that study. But to my knowledge, I don't even know if they're using it off trial. It was just a study that they did.
And Nancy, I mean, the concern of using it, as you mentioned, is really driven by, I want to point out, it's really driven by kind of the outcome of those trials rather than the safety, because, we've been using immunotherapy concurrent to radiation treatment for many other type of cancer. So it's really not about the safety, I would say, but about the kind of negative results of those previous studies.
Yeah.
Perfect. Okay, great, fantastic. So it's 7:30. Let's start the last presentation, and hopefully we have time to have more discussion and talk about different aspects of modern care. Dr. Lim.
Can you see my slides?
Yes. If
Just
you
a
put on
second.
presentation mode.
Here you go. All right. Thanks so much for having me here. So I'm Tri Ming Lim. I'm a head and neck surgeon based in Singapore. Thank you for the opportunity to share some of the insights in managing this highly endemic cancer in Asia. All right, and no specific disclosure pertaining to this talk, although I'd like to recognize my training by the American Head and Neck Society in Pittsburgh Medical Center. All right, so in the next 12 minutes or so, I'd like to run through a surgical perspective in salvage for recurrent NPC, touching not just the ablative part, but the reconstruction aspects, and then discussing the possible role of adjuvant VRT in this setting, and finally, some of the future directions that we may be undertaking. So NPC, highly endemic in Asia Pacific, EBV associated. We heard that the standard treatment for de novo cases will be radiation with or without chemotherapy in a non-metastatic. If you look at the histopathology, certainly EBA is a highly used surrogate marker to confirm the EBV positivity in this cancer. This is the current treatment paradigm in Asia that we discussed, and we'd like to focus today on a recurrent, non-metastatic, in terms of giving for the surgeons to participate in the treatment. So recurrent NPC occurs about 10 to 15%. Whenever feasible, surgery will be preferred, at least in Asia centers. And we typically identify patients who are early, i.e. T1, T2 disease, and very selective T3 cases. This is a study that was published in Lancet Oncology by the Sun Yat-sen group, where they show that endoscopic nasopharyngectomy patients with recurrent resectable NPCs, they are randomized either to endoscopic resection versus re-IMRT. Certainly, the surgical arm did better in terms at the 3-year overall survival. This is how the survival looks like in these studies. And when they compare also the toxicities between the two groups, certainly the surgical treated groups certainly has a lesser grade 4 and 5 side effects in these studies. Nevertheless, re-RT in terms of recurrent NPC is also relevant because not all the patients are surgical candidates for treatment. And this is a nice review by our group in Singapore, where they look at some of the prognosis in delivering re-RT in this recurrent setting. On the surgical front, this was a published data among the Asian surgeons managing recurrent NPCs. Essentially, it summarizes some of the approaches that has been published in terms of resecting this recurrent NPC. But in general, broadly speaking, there's a natural orifice, i.e. mostly the endoscopic technique, where this is done through the nostril, the nest, and we have certainly very good exposure to the nasopharynx, although the limitations will be confined by the narrow space for instrumentation and controlling the internal carotid artery if the tumor extends laterally towards that area. So this is an example of patients that will be an ideal candidate for salvage endoscopic approach, highly small tumors, confirmed not just endoscopically, but also in the MRI imaging. And for this group of patients, sometimes we are unable to reconstruct the nasopharynx with a nasoseptal flap because of the proximity to the postural septum. And in majority, most of these patients do heal well, although we have a minority of patients that have persistent crusting after surgery. Therefore, whenever feasible, during endoscopic nasopharyngectomy, we would like to resurface the nasopharynx with a nasoseptal flap. And this is how it looks like after healing. Unfortunately, a small group of patients, unfortunately, are not amenable for the endoscopic approaches, and the maxillary swing will certainly be a workhorse for open approaches for salvage nasopharyngectomy. And this was first described by Professor William Wei in Hong Kong, and this has been certainly adopted in many cancer centers in Asia. So this example of a patient, how the surgical identification of the incision looks like. And this is the exposure that we have after a maxillary swing approach. This is a video just to demonstrate the exposure after you have the whole anterior maxillary swing laterally, affording excellent exposure to the nasopharynx. And this is the endoscopic view after resection. Certainly, you can see your lateral limit surgically will be internal carotid artery, and posturally is limited by the cervical vertebrae and the clival bone. So this is another example of recurrent. We use a combination of CT and MR for staging for that purposes. Even small recurrences, because of the proximity laterally, sometimes will still necessitate the use of an open maxillary swing. This is the defect that just to highlight that the pharyngeal basilar fascia, which is this glistening white fascia, certainly demarcates the posterior limit in terms of having your deep margins whenever we do surgery for nasopharyngectomy. This is an example of the surgical specimen, and we ideally would take intraoperative frozen sections to confirm that the margins are negative. This is an example of patient after a max swing 6 months later that heals relatively well, and this is the endoscopic view of the flap that was done using a free flap reconstruction using the radial forearm flap for these patients. Well, unfortunately, not all patients are candidates for surgical salvage. Some of these are clearly not candidate because of intracranial involvement. but also be mindful of subtleties such as perineural invasions that are illustrated here, and also for significant clival erosion that will not be an ideal candidate for salvage surgery. MPC also peculiar because there are unusual sites after recurrences. Example of such cases will be frontal sinus recurrence, not a typical site of recurrence, but this was biopsy proven to be recurrent, and skull-based recurrence that sometimes necessitate a sphenotomy and biopsy that was proven to be recurrent MPCs. At the same time, because patient had received prior radiation, I think osteoradionecrosis can be a differentials in this group. In this particular patients, there was biopsy and never proven to be recurrent and was eventually diagnosed with ORN. In MPC, because the first echelon of nodal metastasis will be the retropharyngeal lymph node indicated on the MRI right here, and then on the PET scan on the right side. This is not a patient for retropharyngeal neck dissection, but just to illustrate the deep-seated location of this particular site of recurrences that is technically challenging for surgeons. And the approach that we typically would afford to treat this group of patients will be a maxillary swing approach and resurfacing the area. In terms of post-treatment after surgical salvage, margin certainly is a key in minimizing the risk of local recurrence. So a positive margin would carries a risk of approximately 30 to 40%, whereas a negative margin would be the range of 10 or less %. Overall success across many groups is approximately 70% local control, up to 30%, however, suffer from distant relapses in the future. So this is a paper that was just published last month in the Rate Journal, pooling some of the consensus among groups of physicians as well as surgeons managing recurrent MPCs. And certainly you can see that there are no unified consensus, even among the clinicians managing this recurrent setting of MPCs. In terms of resectability, there's fairly uniform consensus in terms of what constitute resectability, although there are some particular instances where there still is not 100% consensus in terms of what constitute resection, like recurrent T2 abutting close to the internal carotid. I think there's not a uniform consensus in that regard. In terms of definition of what constitute a close positive margin, generally, I think most people take more than 1, less than 3 as a close margin, although some of the group members felt that the true positive margin will be on the ink margin on the resected specimen. And the indications of post-op VRT in this setting, most would agree that that should be considered, especially in the setting of close to positive surgical margin. Just to highlight, this patient had a salvage nasopharyngectomy 5 years. The margins was close, but he declined adjuvant. Subsequently, he had a recurrent in the sphenoid sinus indicated here. Very subtle, but eventually proven and had to receive chemotherapy in this setting. On the relapse status, we certainly showed that patients who had recurrent cancer do poorly than those with residual disease, meaning patients had persistent residual disease 6 months, less than 6 months after definitive treatment. Well, in the final 2 minutes or so, I'd just like to highlight some of the future directions in managing this group. Certainly, we talk about liquid biopsies, certain spectroscopy in order to pick up local recurrence a bit earlier than when it's visible on the naked eye. In terms of trials, this was the NCI meeting where we look at some of the potential trials that we can incorporate in the recurrent MPC setting. After retreatment, be it surgery or VRT, randomizing them to receive IO in the adjuvant setting. And this is a study open in Asia Pacific where they look at borderline resectability of recurrent MPCs receiving neoadjuvant pembro with chemotherapy. And then after that, whenever possible, the patient will receive surgery and then followed by adjuvant pembro in this setting for recurrent MPCs. In terms of immunotherapy, like what previous Dr. Prefico mentioned earlier, certainly cell therapy is gaining some traction. Several trials in Singapore looking at dendritic cells and natural killer cells demonstrating some modest effect, approximately 10% to 15% objective clinical response. So then my group is interested in TILs, and this is just to show the spheroid models, how treating MPCs with TILs harvested from the primary tumor does exert some efficacy in the preclinical models. All right, so the take-home message is that recurrent MPC occurs about 10 to 15%, and whenever feasible, surgical salvage is warranted. Early diagnosis of this recurrence is therefore key for improvement outcomes, and there are clinical trials required to test the feasibility of adding immunotherapy in this particular setting. All right, with that, thank you very much for having me. Happy to take the questions after. Thank you.
Fantastic. Well, thank you so much. I cannot thank all of you enough. I think this is the first time I've seen a panelist that all finished on time, when actually we have like 15 minutes for questions. So fantastic. You're all always invited to any panels. This was amazing. Now we are officially entering the after party where all the action happens. So let's start with the audience question. The first question is about the EBV DNA copy number. Is there a cutoff? How do you use this data practically? How often to test, and what is useful, what is not useful? Who would like to comment on that? Role of EBV titers in the primary diagnosis and also for surveillance. Is there a cutoff number?
Sure. At least from energy oncology and coupled with NCI, we use more like a qualitative approach. It's either detectable or undetectable. So pre-treatment, you will draw the EBV DNA, not so much the titer, but really plasma EBV DNA. And then after treatment, if it goes from detectable to undetectable, that is what the trial's written. Can we omit therapy? Now, in terms of cutoff, we had a lot. I mean, in Taiwan, it was 4,000 or 1,500, and then Anthony Chen from Hong Kong was 500. We went through all permutation. If you look at all the paper published, which is a lot, there's even meta-analysis done. But in the end, really, these are PCR-based tests, very sensitive. And so basically, the ending is that we go down to the limit of detection, probably around 5 or 6 copies per ml. And then when it's above that, that is considered detectable versus undetectable. But very good question. Right now, my understanding, no one is using it as an integral biomarker, meaning we take the DNA, we said, let's make a change in treatment. Head and neck 001 will be the first trial, if positive, where we're going to use it as an integral biomarker. There's a lot of integration. People say, oh, if you have a positive, negative, prognosis-wise, there's a lot of papers on that, but not as an integral biomarker.
How often do you check it after treatment?
Great
Every other
question.
week? Once a year?
Great question. That's a lot of debate. When we looked at energy oncology and then multiple trial, you want to check the first time after treatment about a week after. If you wait too long, the patient might have recurred too late. And that's what happened with some of the Hong Kong study, Anthony Chen study. Then there was some data saying that if you are detectable, first check after chemo radiation, after your definitive treatment, you may want to check the second time, a month later. If that goes to undetectable, the prognosis will be the same as if you're upfront undetectable after treatment. And then we have it, so then I have to say, this BAM-H1, I didn't have time to go into it. Dennis Low assay from Hong Kong, they look at the repeat region of the EBV genome and perfected BAM-H1 segment. And for that technique, many labs cannot do it. It has to be credentialed. There was a harmonization effort in the US and Taiwan, Hong Kong, Singapore, etc. And so far in the United States, just Stanford and MSKCC, that's CLIA certified, meaning we can use it as a clinical test. And then from that, you may want to check it. I kind of now do it, Babak, like whenever I see patients, I just get it because we have that test.
So basically like every 3 months in the first year?
We can, but people still want to have their PET scan, right? That's like, we are in that transition. Like we feel better if there's a PET scan. But I think personally, ultimately, with the way healthcare is going and the cost of these scans, blood test is the way to go. So, be much cheaper. And if the blood is rising, then we get a PET scan.
See,
May
what?
I add? May I
Yes.
add? In the recurrent, totally agree. In the recurrent metastatic setting, EBV can, for those who obviously have detectable and they have EBV positive, is also used in the clinical practice. For example, in my practice, I tend to use it, and I tend to time it either around in the time of the CT scan, or sometimes I time to do it a little bit more frequently for those patients who I am concerned, for example, that they might be progressing, and then decide to anticipate it, the CT scan eventually, similarly to what other kind of tumor marker are used in other settings, such as in ovarian cancer, CA-125 and so forth. I tend to use it, and so in those centers that have the ability to do so, then I assume several other colleagues will do that.
You're muted, Dr. Gibby. You're still muted, sorry.
Babak, you're muted.
Okay, well, thank you. Now, since it's the after party and I'm the moderator, I'm going to put everybody on the spot. And I'm going to say, okay, it's 2024. And now this patient, young person, comes to you. And I'm going to ask each one of you, recurrent, looks like a small disease here. Let me see. Here and here. And this patient shows up to your office first, Dr. Lee. You didn't treat her, but it's like, what would you do now? Do you warm up the machine right away? Do you send to Dr. Sprifico, or you send to Dr. Lim, say, go see the surgeon first, or you see systemic, or say, no, I'm just going to treat this right now?
So this patient had chemo radiation. When did the patient complete the treatment?
3 years ago.
3 years ago. You have this mass. First, it's biopsy proven, right?
Correct.
It's biopsy proven. Well, the cross-sectional imaging, is that the one that you show? The other one?
Correct.
I just want to see the extent of disease. Do we have?
It's like a chip shot for Dr. Lim. It's like nothing.
Okay. We don't do too much Dr. Lim endoscopic resection, salvage surgery, although we do have a surgeon that will look at the case. And we typically, if we can take it out with a negative margin, that is one option. I used to be very big on re-irradiation, but I have learned a lot, because if you live a long time, you might see the complication of second course radiation. So I typically will see, are there options outside of VRT? If surgery can do a great job, I don't have a problem, as long as I don't have to give VRT after surgery. And then if it's really extensive, I think immunotherapy may be a good way to go. And then, and we also do VRT with chemotherapy. We discuss as a DMT and feel that it's safe to give a second course radiation.
Okay, so ball or strike. Patients in your office, you gonna say, go see Dr. Sprifico, or you're gonna see Dr. Lim? Which one? Which way your heart goes?
With my heart goes, I'm going to see all three. All three of us will see. Then we're going to have a multi-D. That's really the reality. In this case, I feel like you need more slices, Babak. You give me one slice.
Fair enough. Fair enough.
Then I'm like trying to figure out, is it invading the skull base or not? Or is it just localized and small?
All right. So Dr. Sprifico, again, same question for you. Patient comes in. What would you say? You say, let me just give you some chemo immuno first, and then we'll see. Or you say, no, let's see the surgeon first, or see the radiation oncologist. What would you say?
I think I agree totally with Dr. Lee. I think the important message I think here is that this type of cancer, like many other, but this type of cancer is a cancer that needs to be treated with multimodal. So this is a type of cancer that multidisciplinary approach is very important. So I would actually bring this case at the tumor board so that we have the entire group reviewing the images, reviewing the plan, reviewing how the patient has tolerated. What are the side effects that the patient is carrying on after, you know, the chemo radiation that had 3 years ago, and what is the extent of the disease at this point before deciding it and jumping it. I would not jump onto this unless I have, you know, reviewed this with the colleagues to make sure we make the best treatment approach and guide the patients on what the next steps are.
Well,
Patient may not want to do surgery depending on the extension as well. So we need to consider also what are, you know, the goals of the patient.
okay, well, Dr. Lim, nobody wants to radiate, nobody wants to do immunotherapy. It's in your court now. What do you do now?
Well, it's the same. In Singapore, we have a multi-D because, like I shared earlier, sometimes the subtleties of the disease may not be very obvious, like what I pick up, like the perineural, and in those settings, and we generally would not prefer to operate. And even we look at like the clinical context, whether the patients already have treatment-related side effects, and that generally governs how our radiation oncologists will decide whether RRT is feasible. There's no data, to my knowledge, whether you can effectively give RRT for close margins and then helps to, you know, there's no clear randomized kind of studies, but anecdotally in that setting, it does improve the organ control. Yeah, so but this case, I'm not sure whether he's also a candidate for endoscopic approaches because it looks a bit bulky. And some of the cases that we see for recurrence that it is quite infiltrated. It doesn't recur like a tumor, but rather it is fairly infiltrated, going into the planes. And this group of patients, if I would prefer an open approach in this setting, and also resurface that's nasopharynx with a flap. And I think in that setting, the carotid at least is well protected in case patient needs to get RRT. I personally feel safer in that setting.
Okay, so you think that surgery is an option, but it looks like an open approach. You show the picture to the patient passes out in your office. They run back to Dr. Lee, who said, I can't have that operation. So Dr. Lee, would you at that point saying that, okay, RRT is an option? And if you do RRT, would you do immunochemo first? You do concurrent? What would you recommend based on what data that we have?
Absolutely. I mean, we, of course, RRT is always an option. It's really when do we do RRT? So like I said earlier that I used to jump in very fast, but then I think this is a really big discussion regarding should we do some type of systemic therapy, shrink the tumor a little bit, because in RRT setting, unlike the first setting, it's all about your field design. The smaller the RRT volume, right? Less normal tissue in your radiated field, less complications. So I always like to go to the smallest field that I need to. I don't prophylactically treat the prophylactic area because you're just at risk because that area already received prior radiation. So so that's sort of the approach we do. And then if we do RRT concurrently, we would not give IO because of the negative data in the definitive setting. We would give it with typically platinum or some type of gem-cis combination or something like that.
So Dr. Sprifikov, patient comes back to you now, says, well, they gonna do RRT, but they asking for systemic therapy first. What would you do? What kind of systemic therapy now you recommend based on the new data?
So what we have in terms of data for induction type is certainly what we heard about it. It's cisplatin and gemcitabine induction. That said, those data are for patients who have de novo disease and not necessarily recurrence of the disease. One approach would be to consider the patients, you know, not suitable for surgery, too high risk for, you know, additional toxicity. So then I treat the patient technically under a palliative approach that includes, for example, chemoimmunotherapy upfront without a plan for necessarily radiation, and then just monitor the disease and see how the response is. should there be the disease, then I will just bring it back to the tumor board. But as I said, that will have to be if surgery is not feasible, is radiation is not the next step. If the radiation oncologist asks me about shrinking the tumor, I will be questioning whether or not the sole chemotherapy with cisplatin gemcitabine induction would be necessarily favorable here, given that the patient is not de novo. This is a recurrence.
Okay. All right. We have 3 minutes. There are a couple of very good questions from the audience. The first one is for Dr. Lim, and it's a technical question. How do you assess margins during the surgery? Do you send frozen section? These are post-radiated, difficult, but how do you assess your extent of resection?
Yeah, thanks for that. So we do intraoperative frozen sections. Typically, because it's a nasopharynx, we usually do on the defect kind of approach rather than on the specimen, because the specimen typically when you remove it, it's a bit hard to get nice margins on the specimen itself. So we take it from the defect, at least that's what I do. Whenever possible, if it's proven to be positive, we attempt to do a resection intraoperatively to achieve a negative margin. But even in that setting, I think the outcomes are, at least from the data, is even poorer. That means you get a positive intraop and then you do resection to get so-called negative. And those group of patients also do not do as well as those who have upfront negative margins.
Okay.
And that setting, yeah.
Go ahead.
And this setting, we will discuss with the patients in the tumor box whether a re-RT setting will be appropriate. Yeah.
Okay. And the question for all of you is, let's say there is a suspicious findings on PET-CT in a very hard to reach area, such as orbital apex. How much do you push for getting a biopsy? Or at some point you guys say, you know what, it looks like a cancer, acts like a cancer, we're just gonna treat. But how do you approach these really hard to reach areas for biopsy?
Great question. I would never give ERT without biopsy proven disease, because after treatment, you can have a lot of abnormality. And in fact, skull base is one area where they never look normal. It may look suspicious, but I would never, because we're going to run into complication risks. Surgeons get really mad at me when I want you guys to give a biopsy proven disease, but sometimes we will monitor. And this is where EBV DNA can help us. If it continues to rise, and then, suspicious, and maybe at one point we will have to consent the patient. But it will be a very, very detailed consent to make sure they understand that we don't have tissue diagnosis, and we're operating on assumption of, like, for example, EBV DNA imaging, and then there may be complications associated.
Perfect. Okay, it's now 7:59. I think we are at the end of the session. Thank you so much. This was an amazing, very comprehensive and very timely talk. I really enjoyed all of you guys talking. I think I learned a lot. Any last comments or last thoughts or points for the audience? Dr. Lee?
No, I just thank you so much for having me.
Okay, Dr. Sprifico?
Yeah, thank you. It was a great talk, a great discussion. Thank you so much.
Okay. All right, Dr. Lim?
Yeah, thanks so much. No further comments. Thank you for having me here.
Of course. Mike?
I learned a ton. Thank you all so much for being here. Appreciate you being a part of it.
Well, amazing talk. Thank you. It's now 8 o'clock Eastern time. I thank you for joining us for this webinar. We were very fortunate to have the best experts in this topic. This webinar will be posted in our website, and you can see it later. I would like to invite everybody to attend the COSM meetings in next year in New Orleans. And again, thanks Dr. Lee, Dr. Sprifico, and Dr. Lim, and Dr. Michael Moore for joining us. Have a great night. Thank you.
All right. Take care, everybody.